Hi, this is Dr. Robert Chao reporting for Room Now from ULAR 2021. And I just wanted to share with you an excellent talk that I just attended. And this was a talk by Dr. Laura Coates, and it was oral presentation 6937. And her talk focused on the personalization or the need of personalization for psoriatic arthritis treatment. A few things we all know that psoriatic arthritis, the disease is very heterogeneous. There's many disease facets, and every psoriatic arthritis patient is different from the next. In terms of the treatment of such, we know, for example, for peripheral arthritis, we have a heck of a lot of therapies, but they roughly all do the same. You look at their ACR 20 efficacy rates, and they're roughly the same, even amongst the newest newcomers. For psoriasis, there is some separation actually. So we know that with IL-17 inhibitors, IL-12/23 inhibitors, and IL-23 inhibitors, they seem to have a better efficacy in terms of PASI 75, 90, and even approaching 100. And I think it's only a matter of time before they start measuring PASI 125, where it cures your psoriasis and maybe a little bit of your cousins as well. Sometimes, we don't always have to, we're not always chosen or given the choice to choose the best or the most efficacious drug. We are stuck trying to navigate between a patient's comorbidities. For example, fatty liver disease. We know that for patients with fatty liver disease, we tend to avoid methotrexate, leflunomide, sulfasalazine, and NSAIDs. We know for chronic kidney disease patients, we need to avoid methotrexate and NSAIDs. And we also know that cancers also make us very uncomfortable in terms of treatment, and especially biologic treatments. When you shift gears into other facets of the disease, including axial disease in psoriatic arthritis, we have promising and good data on TNF inhibitors and IL-17 inhibitors. And there's some promising data on JAK inhibitors as well. But there's also some negative studies on IL-12/23 inhibitors and PDE4 and IL-23 inhibitors. And perhaps this lends to the thought that axial psoriatic arthritis is different than axial spondyloarthritis. I think depending on where you practice and which country, what continent, we generally follow a step-up approach. And again, depending where you practice, that's going to be an NSAID, a conventional DMARD, followed maybe by another conventional DMARD. And then we go through this labyrinth of different biologics. And I think it's time that we start trying to identify subgroups. I think about 2 years ago at ACR, there was a small study that was very interesting from Japan, trying to genotype psoriatic arthritis patients based on T cell types, based on the cell markers. And this was on Th1 and Th17. And they had interesting results in terms of TNF inhibitor use, IL-17 and IL-12/23. But it was a small study. And I think one of the most promising things from Dr. Coates's talk is the introduction of a new study called Optimize, based in the UK, that's based on this Japanese study. Again, trying to identify subgroups. And what they will attempt to do is randomize TNF inhibitor use versus IL-17 inhibitor use in psoriatic arthritis patients based on Th17 markers. And I think the ultimate question is, will biomarker and drugs link together to ultimately collaboratively achieve a minimal disease activity? So hopefully, it sounds like we have a lot of promising studies and projects in the pipeline, and hopefully we'll have a clear answer the next time you see a psoriatic arthritis patient on what is my most personalized approach to treating you, the patient. So thanks again for tuning in to Room Now for live coverage of ULAR 2021, and feel free to follow me on Twitter at Dr. RBC. Thanks.